Hope I am audible. So we'll begin with today's lecture. So yesterday we completed all the cutaneous malignancies and we also concluded with the basic things which were there in the skin chapter. Basic benign disorders, the characteristic of the skin and everything. So now it is the time we are going to jump to what is called as burns. So burns is a very important chapter when it comes to your PG as well as your NEET PG, and also when it comes to your exams, because burns is almost asked in all the exams, in surgery papers, in your NEET PG questions, and you are also going to encounter them in your day-to-day life. So if you have any problems, you can just post them in the comment section. I'll be more than happy to help. Sorry for taking the lecture early today because I had some work at night, but hopefully we'll cover off all the topic. Those who are going to miss it out can actually see the recorded lecture later on. So let's start. So let's see, the most of the burns injuries are going to happen when the child is going to be there, or when the age of the child is going to be less than 16 years, because the child does not know how to handle warm things. That is the reason most of the burn injuries are actually found out in the children where they are less than 16 years of the age. And always remember that prevention is the primary strategy, because burns are totally avoidable. So at least the accidental burns are totally avoidable. So when I was doing my residency, I've seen that many of the patients who present to the burns OPD or to the burns casualty are those who are actually having all the avoidable reasons. So there was a baby who was playing along with he was playing on the ground. There was some warm water placed there, and he accidentally touched the the warm utensil, and that was the reason he got burned. Or the warm fluid fell on his thigh and he got the burn over the scald in the genital region. So it is very cumbersome. So technically speaking, this all things can be avoided. The most important immediate cause of the death in the burns patient, always remember, it is going to be the carbon monoxide poisoning. So immediate and static cause of death is going to be carbon monoxide poisoning. Then the later, like you can say, that is going to be the hyperacute cause of death. So carbon monoxide is rapidly going to replace the oxygen. You know that it has 250 times more affinity to the hemoglobin. And that is the whole reason that there is no use of checking the SpO2, because in SpO2 the SpO2 might be normal, but the PO2 levels actually might be very low, because carboxyhemoglobin is also bright red in color. So most of the times you can miss out on the oxygen saturation probe. So whenever you are suspecting an inhalational injury, always you are going to do an ABG of the patient, because ABG is going to tell you about the actual PO2 levels of the patient. So then comes the acute cause of the death. The acute cause of death mostly is because of under resuscitation. And the most common delayed cause of death in the burns is equal to sepsis. So this is hyperacute. Within hours it is going to happen. Acute means till 24 hours, and after 24 to 48 hours the delayed causes of death is going to be sepsis. So you should remember that. So how is carboxyhemoglobin going to act? It is going to bind with hemoglobin, almost 200 to 250 times affinations, and it is going to cause functional anemia. So what is functional anemia? The RBCs are present but they are not able to carry the oxygen, and it is also going to bind to the cytochrome oxidase, and it is going to cause cellular hypoxia. Another thing is a cyanide poisoning, which occurs because of the burns of the plastics. That is the reason they say that don't burn the plastic bags, because it releases cyanide into the air and it is directly going to bind to the mitochondria. So we are going to make a small chart wherein we are going to actually see that how the different types of the burns are going to cause respiratory compromise. So respiratory compromise in the burns. So respiratory compromise in the burns. So whenever there is going to be a flame inhalational injury, so there is going to be supraglottic and glottic component compromise. So supraglottic or glottic compromise. Whenever there is going to be a steam inhalation, it is going to cause infraglottic compromise. Whenever there is going to be, as we saw right now, carbon monoxide poisoning, not CO2, it is going to be carbon monoxide poisoning. It is going to cause functional anemia. And whenever we are going to have H2S, that is sulphide poisoning, it is going to cause cellular hypoxia. So we should know the different types of the agents in the burns who are going to be responsible for respiratory failure. So whenever there is going to be a burn, you are going to classify the burn based on the depth of the burn. So how are you going to classify the depth of the burn? So it is given on the basis of the Jackson. If you are going to see a diagram here, the classification of the depth of the burn can be a superficial burn, It can be a superficial dermal or a deep dermal burn, a full thickness burn which can involve even the muscle. So superficial means it is going to only involve the epidermis. So superficial is only epidermis. Only epidermis. So if you are going to draw a small diagram, we will get to know that this is going to be your skin region. Hope the screen is visible. So this is going to be your skin. This is going to be the epidermis. This is going to be the dermis. So you know that the dermis has papillary edges. So whenever the burn is through these papillary edges, so any type of the superficial burn, any type of the burn which is going to involve only the epidermis, it is going to be called as superficial burn. Whenever it is going to involve the deeper part of the dermis along with those rete ridges, so whenever the papilla is going to be involved, it is going to called as a superficial, you can say it is called as a superficial deep burn. And whenever it is going to involve the deeper part of the dermis, we are going to call this as a deep dermal burn. Deep dermal burn. And whenever it is going to involve the underlying muscle and another tissues, we are going to label it as we are going to call this full thickness burn. Full thickness burn. So how are we going to try? So clinically you should be able to differentiate between a superficial burn and a deep burn. So how are you going to distinguish? So always remember that superficial burn is not going to have any blister. So whenever there is formation of any blister, so one thing which we are going to see is blister. So whenever there is going to be a blister, it is directly going to go into the dermal type of the burn. So superficial burn, it is just going to have erythema, only erythema. So whenever you might have seen that you might get across some utensil, you might have touched a hot utensil and you might find out that, oh, the finger is going to burn for next 7 to 15 days. So that is because whenever you are going to touch the utensil, only the superficial epidermis is going to get damaged. There are not going to be any blisters, and always it is very much painful because all the nerve endings are intact, and because of that burn irritating the surface, it is going to cause a lot of pain. And here there is not going to be any scarring because, as we know, only epidermis is involved, so no scarring. When you are going to see the blister, always remember, whenever you are going to see the blister, it means that the dermis is involved, because the epidermis is going to separate. So you know that this is epidermis and this is dermis. So this is your epidermis, this is your dermis. So whenever the epidermis is going to be separated from the dermis, there is going to be fluid accumulation. So there is going to be fluid accumulation at the dermal region, and that is the time you are going to form the blisters, and this is going to be moist blister and the burn is going to appear red. Again, if it is painful, it means that the nerve endings which are going to be present in the papillary dermis, so these nerve endings are intact, and that is the reason when you are going to say that, okay, it is a superficial dermal burn, because pain is going to be present. So appearance of blister, it is a deep burn. So if blister with pain, it is going to be deep dermal burn, so superficial dermal burn. So now we are going to talk about the deep dermal burn. In the deep dermal burn, here the most important thing you are going to find out is that there is going to be fixed mottling. So what is fixed mottling? So let's see a photo. So if you are going to see a photo, when you are going to press the skin, so you can see that there are the blisters. So this is a superficial dermal burn. Whenever you are going to see this, whenever you are going to press the skin very hard, you will find out that it is going to cause blanching. It is going to cause blanching. So basically what is going to happen, the blood is going to just recirculate, and when you are going to release the finger, again the blood is going to come under the skin. So that is called as a blanching, and this blanching, when it is going to be absent, we are going to label it as a deep dermal burn. So there is going to be absence of blanching, yet the tissue is going to be red. So red but no blanching, it is a deep dermal burn. And when you are going to talk about the full thickness burn, that whole of the dermis is also involved, it is going to be a whitish form of the tissue. So here you can see that whole the burn is white, so total white burn. So this white burn is nothing but full thickness burn. So whenever you are going to come across a burn clinically, you should know that whether it is superficial, whether it is deep, whether it is deep dermal, superficial dermal or deep dermal, or it is involving the full thickness. So it is very much important to find out clinically. And how is the burns, what is going to determine the depth of the burn? So it is going to be determined by the temperature and the time of contact. So more the temperature, more is going to be the deeper burn, and more the time of contact, again the burn is going to be deeper. So you should know that these are the important things when you are actually studying the burns concept. So I hope it is very much clear. Again for a point of rule, the trauma or the mode of which the burn is going to happen. So if the burn is going to happen because of scald, it is usually going to be superficial. or it is going to be yes, it is going to be superficial dermal burn. And if there is going to be a flame injury, if the person is going to have a flame injury, if the person is going to land up into actual fire, then that is the time when it is going to have a deep dermal or a full thickness burn. So the mode of burn is also very much important. So if it is a scald burn, it is mostly a superficial burn, so you need not worry about it much. But if it is going to be a flame burn, you need to worry about it, because flame burn, first thing, there might be an inhalational injury. We saw that flame is going to cause supraglottic, airway, edema and stenosis. Second thing, flame is going to cause direct damage to the skin, and it is going to cause, yes, it is going to cause deep dermal burns, or it might also be able to, or it might also cause what is called as a, yes, full thickness skin burn, and it is very much dreadful, because it is going to require debridement later on. We are going to see. So what is Nikolsky's skin? So Nikolsky's skin is nothing but that in cases of superficial burn, the skin is going to slide off. So when there is a superficial burn, when you are going to rub off the skin, the epidermal is going to cause peeling. So it is called as a Nikolsky sign. You are also going to see it in one dermatological condition. If anybody can put in the comments, I'll be more than happy to check for it. Another test from the finger we saw in the first chapter was, we are going to do what is called as a finger probe test. So whenever we are debriding a necrotizing fasciitis, you are going to actually probe the finger, and if the skin is slipping off, then it means that the tissue is unhealthy. So two things which we are going to saw regarding the skin. So one is a finger probe test, second is the Nikolsky sign. So Nikolsky sign is nothing but whenever you are going to slide off the skin, the epidermis is going to peel off. So that is Nikolsky sign. Fixed capillary staining, so that is called as fixed mottling, which we saw. It is a sign of deep dermal burn. So whenever we are going to press the red region, the capillary refill time is not going to go, the red color is not going to go, because the capillaries are permanently dilated, they do not blanch. So it is very much important. Scald burns are usually superficial and flame burns are usually deep. So I hope it is very much clear when we are going to come across these things. So I hope it is very much clear. So what is the first aid? So you are practicing maybe in a rural setup, or you might be doing some your bond in some rural setup. So how are you going to actually tackle a burn? So firstly, rescue your safety. So you are managing the patient. Make sure that you are taking the patient out of danger. So you have gone to some region where it has been burnt. Don't actually go in that burn region to get yourself burned. You are not a krish to go there and actually help the patient. So take the patient out in a safe region, and then you are going to stop the burning. So remove all the burning clothes, remove all the burning jewelries from the patient. But if the clothes are very much adherent, this question might be asked in your NEET exam. Very much adherent clothes not need removal. Check for other injuries. Most of the times what happens, a patient might get burned and fall on from the first floor. So he might have fallen, he might have a spine trauma, he might have a head trauma, he might have abdominal or thoracic trauma. So check for the mode of injury. So mode of injury is very much important. Cool the burn. So 20 minutes you are going to place the burn skin under water. So whenever the burn is on the extremities, 20 minutes of cooling is very much important, and it is only effective if you are going to start it within 3 hours. So the burn, the actual effect of the burn, the lateral spread of the burn, the damage of the burn is going to be restricted. But if you are going to start within 3 hours, same protocol for tranexamic acid in hypovolumic shock. So if you have seen the lecture of shock, I think you will remember that within 3 hours, if you are going to give tranexamic acid, it is going to be beneficial for the patient. Avoid hypothermia, because we saw that the skin also has a tendency to maintain the temperature. So it is very much important that whenever the patient is going to have a large type of burn, the patient is going to have a lot of heat loss. So always remember that when the patient is going to have that heat loss, the patient might land up into hypothermia. We have already seen the lethal triad of trauma, that is hypothermia, acidosis and coagulopathy. So one of the factors is going to set in, other two are going to set up, and that is the reason why the patient might die. And never use ice or butter or toothpaste, egg white, household remedies. So this sentence is literally given in belly love. No household remedies. It is all going to worsen the outcome, because they have a lot of bacteria in them. They are not sterile. So whenever you are going to apply it on them, the skin is already burnt and there is no actual defense mechanism in the skin. So whenever you are going to apply them on the skin, the patient might land up into infection. So it is very much important. So always remember, when you suspect an airway inhalational injury. So this is the first aid about burn. Now we are going to check the patient. When are we going to admit a patient? Because if you are working in a government setup, you should know that the patient should be admitted or the patient should be sent home. So there are few criteria for admitting the patient. So when you should admit the patient? So if you suspect a facial burn or an inhalational burn, so any type of facial burn, even it might be 1% burn or 5% burn, you are going to admit the patient. So suspected airway or facial burn, because the edema is going to peak after 24 hours. So you might send the patient home and the patient will go collapse at home. He will become breathless and patient is going to die. So any inhalational burn, admit the patient. Any inhalation burn, admit the patient. Then burn requiring resuscitation. So any burn more than 15% body surface area. So in simple terms, there is something called as a Wallace rule of 9. Wallace rule of 9. So anybody knows what is Wallace rule of 9? So head, both the arms, anterior chest, posterior chest, anterior abdomen, posterior abdomen. So all the things are given a value of 9 together. So 9 ones are 9, 9 twos are 18, 9 threes are, yes, 9 ones are 9, 9 twos are 18, 9 are 27. So 1, 2, 3, 4. Again you are going to add 36, 36, 72 and both the limbs are 18, 18. So in that manner it is going to come down to 99 and 1% to the genitalia. So you can actually estimate how much amount of the body is burnt. But let's consider that not the whole arm is actually burnt. Some part of right arm, some part of left arm, some part of the chest. So that time you can actually use the palm length of the patient. So the palm length of the patient, not yours. Because if you are doing for a baby, your one palm length will become 1%. So palm length of the patient, when he is going to do it for himself, you will also find out that you can place 9 palms on your arm. So one palm length of the patient is going to be 1% of the burn. So you can either use a Wallace rule of 9 or you can use a palm length of the patient and you can actually find out how much area is burned. So always remember that any burn of more than 15% body surface area, it requires IV resuscitation. So if you are going to do this, IV resuscitation is required and you need to admit the patient. No suitable caregiver at home. So if the patient is alone, obviously you have to admit. A psychiatric patient, because if you send him home, he will again burn himself. Extremes of the age, because the physiology is altered. A baby cannot maintain its temperature as good as a good adult. And even in old age patient, the skin is fragile, the patient might have comorbidities. So poor physiological reserve and poor immune response. So admit these patients and give IV antibiotics. Any types of chemical burns, because the chemicals will penetrate into the skin and they will further cause damage. So you need to check the wound daily for at least 48 hours. So decontamination is required and supervision is also required. Any electric burn, so any electric burn, the problem is not with the local region. So if you are going to have an electric shock to your finger, the problem is not going to be your finger, it is going to be your heart, because that electric current is going to travel all the way to the heart and it can cause arrhythmias. So it requires cardiac monitoring. And in later part of the thing, because of that current traveling through the muscle might get damaged, delayed and later on, and it might cause rhabdomyolysis, which will cause renal shutdown. So anytime you are actually dealing with an electric burn, you should make sure that you are admitting a patient. So no electric patient burn should be sent home. No chemical burn patient should be sent home. Burn to face, hands, feet, genitalia. Obviously, we know that these are places where proper dressing and proper debridement needs to be done. So patient needs to be admitted. And circumferential burns. Why? Because the circumferential deep burns, if they are going to be present over the arm, they are going to cause the venous return obstruction, and slowly by slowly they will compress all the muscles because of their pressure. And that scar will actually cause what is called as a compartment syndrome. So we saw the compartment syndrome in the chapter of wound healing and infections. So that is the time when you should actually do a fasciotomy or what is called as a escherotomy. So anytime you are going to see a patient of circumferential burn on the chest, abdomen, limbs, always or even on the neck, admit the patient, because the patient will progressively worsen and there might be compartmental syndrome or restrictive ventilation risk. So whenever there is a severe circumferential burn over the chest, the patient's chest will not expand and the patient is not going to take up the air and oxygen, and that is the time the patient will actually succumb. So you should always take care and always make sure that you are going to admit these patients. So whenever you are going to suspect any inhalational injury, first thing is you are going to intubate the patient. Any soot in the hair cavity, any burnt nasal hairs, any patient presenting with stridor, so straight away intubate the patient, because the airway edema is going to progressively worsen. Progressively this edema is going to worsen and always you are going to intubate the patient. It is going to peak up in the 24 to 48 hours period. It is going to peak up in the 24 to 48 hours period and maintain intubation for minimum 48 hours before giving an extubation trial, because you will extubate the patient in 24 hours, the patient will again worsen in next 24 hours. 100% high flow oxygen is essential for carbon monoxide poisoning, and we know that 100% oxygen cannot be delivered by NIV or even via your nasal mask or nasal prong. So it requires intubation intubation, and ventilator will give 100% of oxygen to the patient. It is going to displace carbon monoxide from hemoglobin and reduces its half-life. And hyperbaric oxygen is considered for severe poisoning, where the patient is loss of consciousness, the patient might have neurological deficit, or if patient is pregnant, which can cause harm to the fetus. So hyperbaric oxygen therapy, we saw something HBOT when we were discussing about the wounds of the patient, how we are going to manage the patient with HBOT. So same hyperbaric oxygen needs to be given to the patient who are of high risk, where the patient is almost succumbed, so loss of consciousness, neurological deficit, or the patient is going to have pregnancy. So that is the time you are going to actually go for the hyperbaric oxygen therapy. And as I said, very much important clinical parameter, do not be reassured if the SpO2 is normal, because carboxyhemoglobin will also give the normal. Pulse oximetry cannot distinguish between oxyhemoglobin from carboxyhemoglobin. Hence, always you are going to go for an ABG. If you don't have a co-HB level, always you are going to go for acid blood gas analysis. Always go for an ABG of the patient. So it is very much important. So now comes to the burns resuscitation. So there are two school of thoughts. Both are given in Bailey Love. Both I have tried to mention it to you. So in UK, they think that any burn patient, what is going to happen? So this is going to be our endothelium. This is going to be the normal tissue. So whenever a burn is going to happen, there is a lot of inflammation, and these endothelial channels are going to become leaky. Because of that, not only the fluids, it is also going to pull up albumin. So whenever a burn patient is going to come to you, all the magic molecules of albumin are going to be present in the interstitium and not in the blood vessel because of leaky capillaries. So what happens is, actually, even if the patient is having a lot of fluid in the body, because albumin is osmotic, or it acts as an oncotic pressure, it is going to pull all the fluid in the periphery, and intravascular volume is going to reduce. So what UK people have done the studies, they found out that albumin can be started straight away within 24 hours to the patient. But America says that no, the vessels are already leaky. The vessels are already leaky. If you are going to give more albumin to the patient, the leaky vessels are again going to release all that albumin, and it is again going to cause fuel to the fire. And that is the reason the patient will have progressive worsening. So that is the reason they came out with another formula, which is called as a Parkland formula. So Americans prefer giving crystalloids and UK people prefer giving colloids. So both the formulas are the same. Basic formula is the same. So what you are going to do, you are going to multiply total body surface area with the body weight. So a 70 kg man with 20% burn surface, so it comes down to 2100. But when you are going to give a colloid, the multiplication factor is 0.5. So multiplication factor is 0.5, and when you are going to give a Parkland formula, the multiplication factor is 4. So you can give more crystalloid to the patient, but when you are going to give a colloid, you are going to give it in less amount. So when you are going to give albumin, the multiplication factor is 0.5, and when it is Parkland, it is 4. What they found out later on, that when you are going to give this much amount of fluid, so let's consider a 70 kg man. So what I'm talking about, a 70 kg man who is having 20 kg burn surface. So I'm already bad at maths. So when we are going to multiply, so that is the amount of fluid the patient is going to require. The multiplication factor is 0.5 for colloids, and it is going to be into 4 for crystalloids. So it comes down to 700 ml of albumin. So 100 ml albumin bottle is going to cost you somewhere around 3,000 to 4,000 rupees. And multiplied by 4, if you are going to multiply, it is going to come down to 5 liters of fluid. So 5 liters of fluid versus 700 ml of colloid. So that is the difference. But when they found out that Parkland fluids were given to the patient started to worsen because of pulmonary edema. And hence, they actually brought out what is called as a modified Parkland's formula, which is not given in the books right now. Some books might mention it. So modified Parkland's formula, he decided that now we should reduce the multiplication factor by half. So the new modified Parkland's formula has a multiplication factor of only 2. They say that under resuscitation is fine, but over resuscitation will cause more complications. So what is important is the multiplication factor. In the Muir and Barclay formula, the multiplication factor is 0.5. In the Parkland formula, the multiplication factor is 4. But what are you going to actually do when you are going to see the patient? Based on the patient's nutritional score, based on the patient's condition, you can decide what type of fluid you are going to use the patient. And always remember, this albumin, this one share of the albumin, initially you give it in first 4 hours, then later 4 hours, then again 4 hours, and then you are going to step down to 6 hours, 6 hours and 12 hours each. So that is the amount of infusion you are going to give the patient. And here, this total fluid is divided into 2 halves. One you are going to give it within 8 hours, and the second half you are going to give it within the next 16 hours. So that is the actual formula which you should be knowing. Both formulas are important for in the point of view of your MCQs, in the point of view of your NEET PG exams, and also your INI CET exams. So very much important for you to know. This 50% is given with first 8 hours and next 50% over the next 16 hours. And crystalloids require 8 times more fluid than actual loss because of the edema formation. So when you are actually resuscitating the patient of the patient of burns, so almost 8 times more crystalloid is required as compared to the colloid, because that fluid is going to go into the interstitium. So what are the circulatory changes in the burns? So whenever a patient is going to have burns, as I said, more than 15% total body surface area, when the burns is going to be more than 15% body surface area, that is the time when you are going to actually see the patient, like you should know that the patient is going to have some systemic problems. So what are the systemic problems the patient is going to have? So first important thing is the Hegman factor is activated because of heat. We know that it is the factor of, yes, we know the factor of intrinsic coagulation. So 12, 11, 9, 8, 10. So that is how we are going to do. So 12 factor, 11 factor, 9th, 8th and 10th factor. So that is the intrinsic clotting factor. So whenever there is going to be heat, the Hegman factor, the 12th factor is going to increase, and that is the reason the coagulation cascade and complement activation is going to take place, and patient is going to have microvascular thrombosis. So that is a very much important factor. There is going to be capillary leak because of the hypovolemic shock, and the gut mucosa can go under ischemia, and because of that the gut mucosa undergoes ischemia, and the bacterial load from the gut can also enter the system and cause sepsis. So right from the skin, even the GI tract can lead to the sepsis in the patient, and therefore enteral feeding is critical, because when the patient is going to have burns, the body will think, okay, the gut is not functioning, all is coming by IV, so I should cut the blood supply of your intestines and divert the blood supply to your yes, you should divert the blood supply to the skin. But when you are going to give something orally, the body is going to know that, oh, the gut is functioning, so I cannot cut off the blood supply of the gut, and I should keep the gut blood supply on. So that is the time the body is going to maintain its gut integrity, and that is how you are going to actually manage this patient. So start off within RT feeding within next 6 hours. We already saw the ERAS protocol, so always follow the ERAS protocol. So some factual things about burn dressings. So normally we are going to give a silver sulfa, SSD, silver sulfa diazine dressing. It is usually used in moderate contamination, and the dressing needs to be done every 1 to 3 days. Then we saw something which is called as a deoderm patch. So it is also going to have some antibacterial properties. It is going to keep the moisture, and it will cause autolytic debridement. We also saw that deoderm dressing in the different types of dressings we saw in the type of wound healing. So Berobrain dressing, it is a biosynthetic dressing, and it is going to promote epithelialization, and once you are going to apply this membrane over the burn dressing, you need not worry, it is automatically going to peel off itself. The cerium nitrate cream, it is used for full thickness and heavily contaminated. So cerium nitrate, normally if you are going to apply it on the normal skin, it is going to cause intense pain, but when a full thickness burn is there, already the nerve endings are lost, so you need not worry. It is going to promote epithelial proliferation, and it is also going to enhance the immunity. Then types of skin grafting. So what is cadaveric allograft? It is a temporary graft. So when a person is going to die, his skin can be harvested and can be kept in the skin banks. So what do we do whenever a patient of burns come to us? We are going to apply it on the burns patient, and what is going to happen because of that? The skin loss, the temperature loss, the fluid shift is going to reduce. Naturally, the body is going to kill off that graft later on, but for the time being, it is going to prevent the actual, the physiological derangement of the patient. So biological temporary dressing, excellent wound bed preparation for grafting later on. And then you can apply some silicone sheets, but it is non-adherent, a traumatic removal, and preserves the new epithelium. So best dressing principle, it should be easily available, it should reduce the pain, simple to manage, and promote the healing. There is no single best dressing in any type of burn patient. So match the wound to the wound depth and the contamination level. So if you are going to apply very painful cream on a superficial burn, the patient is not going to come back to you, because he'll say the doctor is mad. But and when you are going to apply a very, you can say very kind of a mild cream on the full thickness burn, the patient will end up into sepsis and he will not see you again. So you should know what is the depth of the burn, how are we actually going to manage the patient, and what type of creams are essential. So that comes down to one important thing which is called as a Jackson Burns model. So what is a Jackson Burn model? Whenever there is going to be any burn to the patient, there is going to be a central zone of total necrosis. So this tissue is dead. I need not worry about the tissue, but the tissue just out of it is a tissue of zone of stasis. So what happens whenever the patient is going to get you with the burns, this already dead tissue is already dead, so it is nothing to do. You need to excise it, or the body is going to clear it off automatically. But this zone of stasis, here a lot of inflammation is going on. So what happens is, when it is 1 to 2% burn, it is hardly of any matter. But whenever the burn is extensive, this zone of stasis can extend up to 40 to 50%. So the burn is actually, let's say 20% of the total body surface area is burned, but the zone of stasis is almost nearing to 40 to 50%. So as a physician, as a surgeon, your role is to resuscitate the patient so that this is saved. So the zone of stasis should be saved, and along that there is some edema and inflammation, that is nothing but zone of hyperemia. So whenever a patient is going to come to you, your role is proper resuscitation of the patient so that the zone of stasis does not convert into zone of coagulation. It should convert into zone of hyperemia, and then it should convert into normal skin. So that is important when you are talking about the depth of the burns. So what is the surgical management? So whenever a patient is going to come to you, you are going to categorize the patient with the 3 windows. So what is the first window? So whenever a patient comes to you, the first 72 hours of the patient, the pain is the important factor. Pain and sepsis is the important factor. But initially, what important is pain. Because of pain, we saw that there is trigger of adrenaline, catecholamines. Because of pain, there is going to be a lot of responses in the body. We saw that in the chapter number 1. So always control the pain. Keep the patient hemodynamically stable, pain management, and early surgery can be safe in this patient. So whenever you think that the patient can be taken up for early surgery, after managing pain and patient's nutritional status and also the patient's general condition, you can take the patient for surgery. Hemodynamic window. So usually what happens is, after 3 to 5 days, when you are actually given him a lot of fluids, the patient body is settling down. So that is the time the ADH is going to be released, the fluid shifts are going to happen in the body, and the hemodynamics are more predictable. So after 3 to 5 days, the patient is going to actually settle down and you can actually predict the response. And then comes the bacterial window at day 5, wherein the colonization is going to exponentially increase. So here the surgery, if you are going to do during this period, then the patient might suffer with sepsis and septic shock. So whenever you are going to treat the patient, try to achieve the surgical management in the anesthetic and the hemodynamic window within 5 days. So any surgery in the burn patient not to be delayed after 5 days, because after day 5, then the sepsis component sets in and you cannot do a surgery. So a simple example, a patient has come to you with extensive burn, and the patient you are planning to take up for a skin grafting. So a skin grafting done after day 5, there are more chances of graft failure because of sepsis and local infections. The same patient, if you are going to do the grafting in 2 to 3 days, the graft uptake is going to be high because already blood supply is rich, the inflammation is triggered, and the graft is going to be uptaken well. The bacterial colonization is going to be low. So whenever you are going to take the patient for any surgery, try in the burns patient, try to make sure that you are going to operate the patient within first 2 to 3 days. So that is very much crucial. So pain management in superficial burn, as I said, it is very much painful, but again it can be managed with oral or IV simple analgesia. No level of high analgesia is required. When we are talking about the patient of the deep burns, then during the dressing time, typically the patient is going to wince in pain. So here the continued opioid injection can be given, and along with that, if the patient is hemodynamically unstable, you can give ketamine or you can add a tramadol to the patient. And in ICU, actually the patients are almost in coma or in sepsis, the patient might not even respond. So ketamine infusion can be given, or if the patient procedure is too much painful, propofol can be given. And in cases of neuropathic type of pain, gabapentin can be added. So this is the pain management. We saw WHO pain management ladder. So in that ladder, we saw first is PCM, then comes the NSAIDs, then comes the basic opioids like tramadol and morphine, then comes higher opioids like fentanyl, and then comes the epidural analgesia. So here what is important is, when the patients are going to present to you, whenever the patients are going to present to you, based on the category of the burn, you are going to manage the patients. And always remember, early tangential excision of the skin and grafting is going to reduce the patient's infection risk, ICU stay, and mortality. So in burns, take the patient straight away to the OT if you feel that the patient is graftable. Escherotomy, so longitudinal incisions are taken. So this is the torso of the patient. So let's consider that this is the patient, this is the chest of the patient, excuse me for the drawing, this is the abdomen of the patient, and these are the limbs of the patient. So whenever you are going to see a patient, you are going to place longitudinal incisions and connect them with H shape. So what is going to happen? The skin is going to expand and the skin is going to get released. Because of that, the patient will be able to breathe. Because in cases of circumferential burns, the skin goes into contracture, there is coagulation in the skin, and that is the reason the patient won't be able to breathe. So even on ventilator, the chest wall is not expanding. So when the patient is not maintaining saturation, even on ventilator, you should straight away do an escherotomy, which can be even done bedside in the ICU setup. So then nutrition is not optional. Nutrition is not optional. It is mandatory in all the burns patient of more than 20% body surface area. And start the enteral nutrition within 6 hours of the burn. It is going to promote gut mucosa, reduce and bacterial contamination. The patient is in hypermetabolic state. So we already talked that 2 to 3 times more calories are required to this patient. So whenever you are treating the patient of burns, 2 to 3 times more calories required, and normally a person requires 1 gram of protein per kg per day. Here in burns, that is going to step up to 2 gram per kg per day to support wound healing and immune functions. So don't hesitate in giving patients the protein powders and high protein diets. It is very much important. Maintain warmth, because we saw that the patient might land up into hypothermia and the patient will actually die because of it. And again, in the first chapter, if you remember the last line of the first chapter, we had seen beta blockers, propranolol. It is going to reduce the hypermetabolic response and it has proven benefit in burns patient at least. So start using propranolol in patients of burn, because it is going to reduce the catecholamines, and again it is going to reduce the stress response on the body, and it is going to help promote early healing and early recovery. Now we are going to talk about some special type of the burn. So whenever it is an electric burn, the burns are divided into less than 1000 volts and more than 1000 volts. So if you remember the song of Salman Khan, Lage 440 volt chune se tere. So what is that important? That the Salman Khan is very smart. He knows that high voltage burns are more mortal, so I am going to play with low voltage burns. So less than 1000 volts, it is nothing but low voltage burn. What is the most important concern? It is cardiac arrhythmias. So the Salman Khan's heart is beating fast after seeing her. So he got a 440 volt shock after seeing his heroine, and that is the reason he is having cardiac arrhythmias. So mandatory 24 hours. So ECG monitoring is mandatory for 24 hours. The compartment syndrome is rare because it is not going to cause much damage to the tissues. Rhabdomyolysis is less more common, and urine output, again you have to just maintain a standard urine output because the patients have less rhabdomyolysis. At standard formula can be used for resuscitation, which we use in the burns. So low voltage burns, not a problem. But high voltage burns, when the patient gets stuck to the electric pillar, so it is high voltage burn. So what happens is the burn wound is going to enter from your finger, or it might enter from your hands and might exit from the toes. So that is the time the current has traveled from the whole body. So whole body is going to act as a conducting system. So there is an entry wound and there is an exit wound. So you just see the finger burn and the toe burn. No, there is nothing, small burn, just dress and send home. No. The patient is suffering a lot. The patient has all the parts of his body have experienced that burn injury, electric burn injury, and hence the patient is having more chances of developing cardiac tachycardia or arrhythmias. So more prolonged monitoring is required. These patients, what happens is when the current travels, the current is going to travel from the path of least resistance. So least resistance path is always going to be muscles and nerves. So when the current is going to travel from the muscles and nerves, they are going to cause muscle necrosis, and that muscle necrosis is going to enter into the bloodstream. So that rhabdomyolysis, the necrotic muscle, will actually go, the rhabdomyolysis, the myoglobin from the muscle will go into the kidneys and block the kidneys, and that is the reason the patient is going to land up into kidney failure. And hence they tell you to manage the kidney output more than 2 ml per kg per hour. So normally I told you 0.5 ml per kg per hour, that is the normal urine output in a patient of trauma or in patient of stress. But whenever the patient is in burns, typically with electric burns, the urine output should be more than 2 ml per kg to flush the myoglobulin. And consider alkaline diuresis, so syrup cital or giving injection bicarb IV, it is going to promote IV alkaline diuresis, and it is going to promote the release of myoglobin from the urine. And resuscitation volume, it is going to exceed because the patient is going to have more amount of deeper tissue penetration and destruction, and hence the patient's muscle might develop edema because of damage to the muscle, and it might lead to compartment syndrome. Hence fasciotomy is often needed in these patients. So I hope it is clear. It is extensive, but you should know how the electric burn is managed. So low voltage burn and high voltage burn. So it is very much important. So chemical burns. So what are chemical burns? So whenever the chemicals are falling onto the skin, so acid and alkalis are the two types of chemicals. So whenever acid burns are there, it causes coagulative necrosis. So actually the acid burn is safe for life. So whatever we are going to see, the patient gets trauma with acid, that is going to just cause coagulation on the skin, but it is not going to penetrate the dermis. It is a self-limiting ischar formation. So the cosmesis is poor, but at least the patient is going to live. But on the contrary, the alkaline burns cause liquefactive necrosis, and they continue to go deeper and they penetrate, and it is more dangerous than acid. So alkali burns are more dangerous than acid. So whenever you are going to encounter any type of chemical burn, as we saw it in the normal burn, 20 20 minutes underwater. Here you are going to place minimum 30 minutes underwater, except phosphorus, because phosphorus do not irrigate with water. It can actually pick up all the solid components of the phosphorus, as it is going to ignite when it comes to contact with the air and water. So when the phosphorus comes in contact with the water, it gets burnt off. So the phosphorus is going to burn and going to lit up the skin. So in phosphorus poisoning, no water. But except phosphorus, everywhere you are going to wash the wound with water for over 30 minutes. A special mention about MCQs, because these MCQs come hydrofluoric acid burn. So it is the specific antidote for hydrofluoric acid is calcium gluconate gel, which is applied topically over there, or even you can inject IV arterial calcium for systemic fluoride toxicity. So whenever you are going to have a forensic medicine paper, hydrofluoric acid burn or hydrofluoric acid injury, you are going to make sure that you know that calcium gluconate is a specific antidote for hydrofluoric acid. So what is frostbite? So frostbite is nothing but when your limb is going to be there in the dry ice. So whenever the ice or whenever there is a cold atmosphere around, the skin is going to, because of that cold temperature, the vessels are going to constrict, and because of vasoconstriction there is going to be crystal formation of the tissue, and vascular endothelial damage might occur after some time. So acute rewarming is required. So immerse the water in the, you know that this is going to be a dry heat. It is going to be a dry cold. So whenever you are going to actually see the patient, of frostbite, it is going to be a dry cold. So what is dry cold? It is because there is no moisture in the wound. So it is like a dry gangrene basically. So whenever it is a dry cold, you are going to rewarm this under wet circumstances. So what you are going to do, place the limb in the warm water, and rapid rewarming is very much essential, and avoid refreezing, because if you are going to rewarm the patient and again it is going to go into freezing, then that is the time the patient will have worse prognosis. And on the contrary, there is something called as a trench foot. So trench foot is nothing but when the patients are soldier or the military people are climbing, because of the moisture retained, the sweat, the cold outside, the cold water, the shoes are immersed into the water, it is going to cause what is called as a trench foot, and it is going to give rise to infections. So as I said, the causative factor is going to be wet cold. So here you are going to keep the limb dry and avoid rapid rewarming. So you are not going to immerse the feet in the water, just try to cover it up with some dry cloth, because it is going to warm on its own and automatically the patient's limb will try to recovery. And when you think that the patient's limb is recovering, you will also give him antibiotics, because it is a wet type of the infection, so it might lead to wet gangrene later on. So it is very much important that antibiotic prophylaxis is required in the trench foot. Along with that, there are some prostacyclins like iloprost, which is going to cause the vasodilatation, and it can be used in severe frostbite specialist centers. So when in patients where you can actually have the centers, there are frostbite centers when you are going to go in the mountain regions. So these frostbite centers typically are equipped with these drugs in order to actually release the blood circulation, and actually rapid rewarming is going to help these patients when you are going to give these drugs. So there is a synergism between these two. So that was extensive, very fast, but I hope I have covered the burns module now. So then we are just going to talk some about the skin grafts and skin flaps. We'll try to cover as much as we can in the next 15-20 minutes, and then we are going to stop. If you have any doubts, just post them in the comment section, or else we'll start with the skin grafts and flaps. So plastic and reconstructive surgery. This is the core module of the plastic surgery. Few things you might feel that these are overwhelming because you don't see the plastic surgery daily. What things are required in a general surgery, we saw that the basic benign conditions, the basic malignant conditions, the basic burns, it is required in your day-to-day practice. But plastic and reconstructive surgery comes down to a niche branch, and sometimes you might feel that this is overwhelming. So if you can remember, it's really good. If you can't remember, it's still fine, but it is important if you are getting up for a surgery, or if you are being a surgery resident, these things are very much important. Might not be that much important for UG, so you can straight away skip this chapter and you can move on to the next chapter next time. I don't mind about it. So what are the Hippocratic principles? So first thing is we saw that do no harm. So non-maleficence, we also saw that in the chapter of surgical ethics. The first thing you are going to follow is do no harm to the patient. And then initially started off with the grafts, and then we come to the flaps. So what is graft and what is a flap? I'm going to tell you smartly. any plastic surgery patient, always 6 weeks of minimum smoking cessation is required, because the nicotine is going to cause vasoconstriction and the graft uptake or the flap uptake might be poor. So any patient who is going to undergo any type of surgery, the minimum 6 weeks smoking cessation is going to be required. And what is a Taylor angiosome concept? So as I told you yesterday, the skin is divided into angiosomes. And what is the angiosome? So the blood supply which is derived in the particular region. So this is a skin angiosome concept. So that was given by the Taylor. So as we have the dermatomes, we have the myotomes, and now we are going to have the angiosomes, the skin angiosome concept. So reconstructive ladder always start at the level of lowest drug that achieves a durable, functional and aesthetic result. So don't try to go for complex procedures unnecessarily. Just because you are competent in that, just because you have knowledge in that, just because you have specialty, just because you have degree, just don't try to make the procedure more complicated. The most easy procedure, the most aesthetically accepted procedure, the procedure with least complications and least harm is the procedure you are going to choose for reconstruction. There are n number of grafts, n number of flaps, n number of reconstructive techniques. It's upon the surgeon's choice. There is no gold standard, but what is to be used is in the hands of a surgeon, and a surgeon should choose it wisely. So what is a graft? So when you are going to take up a tissue and apply it somewhere, so you are going to take the skin from the thigh and you are going to apply it on the ulcer over my chest or ulcer over my arm. I am going to take up that tissue without its blood supply. So when you are taking a tissue without its blood supply to some other region and pasting it or sticking it somewhere, that tissue will start deriving the blood supply from the bed of the ulcer or bed of the wound. So that is called as a graft. So graft does not have its own blood supply. Graft, jahan मैं जाऊंगा उधर से ही मैं खाऊंगा. So graft, when you are going to think about graft, think about one thing, that जहां से मैं जाऊंगा वहां से मैं खाऊंगा. So graft is going to be placed somewhere, उधर से वो अपना nutrition लेने वाला है. So it is like a hostelite. It is going to go anywhere and get settled down at that place. Against that, it is a flap. Flap is like मैं जाऊंगा किधर भी कॉलेज को, मैं घर ही खाना खाऊंगा. So whenever it is like it is going to take the blood supply along with it, it is like a localite. So a localite going to the college and coming back, he is going to get his own tiffin from the home. So taking the blood supply from home to the college, it is like using a pedicled graft. So when you are going to lift up a pectoralis major flap, so sorry, that is not a graft, it is a flap. So whenever we are going to take the blood supply along with the tissue, it is called as a flap. So no blood supply graft, blood supply flap. So what are the two types of flaps? So the basic two types of flaps are a free flap and a pedicled flap. So what is a free flap and what is a pedicled flap? So whenever the tissue, whenever you are going to remove some amount of blood vessels and anastomose it with somewhere. So what happens is, a boy from Pune goes to Mumbai, starts residency there and decides that I am going to eat the home food. So what is the home food? He is going to call his auntie or he is going to call his mama, maushi or chacha and tell him that give me the tiffin. So he went there and udhar ke ghar se wo khana chalu kar diya. So that is nothing but a transfer of the tissue. It is called as a free flap. He settled in Mumbai but took the blood supply from local house there. So that is a free flap. To the contrary, there was a person who is a localite and then he goes to the hospital and comes home back, takes his own tiffin along with them. That is called as a pedicled flap. So what is a pedicled flap? So whenever a pectoralis major muscle is going to be taken down to the oral cavity for reconstruction, the blood supply is going to go along with the graft. So the blood supply is going to go along with the flap, and that flap is going to be called as a pedicled flap. So free flap, you are going to use fibula. Along with the fibula, you are going to cut the blood vessels and you are going to anastomose it with the facial artery and facial vein in the face. So that is a free flap. And pedicled flap is nothing but the pectoralis major muscle is taken up along with the blood supply, along with it no vessel cutting, no vessel anastomosis, and then you are going to place it. Same way, thoracodorsal artery flap. The thoracodorsal artery flap, which is the latissimus dorsi flap, you are going to take that latissimus dorsi anteriorly and reconstruct the breast after doing mastectomy. So that is called as a pedicled flap. So you should know what are the grafts and what is the flap. So पहले हम बात करेंगे hostilites की. So skin grafts. So it might be two types of skin grafts, the partial split thickness skin graft or the full thickness skin graft. So what is a split thickness skin graft? So we already saw what is the skin. So if this is going to be the skin, this is going to be the dermis. So whenever you are going to actually pick up the tissue from this level. So whenever you are going to pick up the tissue from this level, this is going to be, so at the papillary dermis you are going to pick up the skin. This is going to be superficial split thickness graft. So STSG, split thickness graft, superficial split thickness graft. But whenever you are going to take the graft below that, along with the dermis you are going to take the graft, it is called as a full thickness graft, FTSG, full thickness skin graft. Sir, what are the differences between it? So firstly, we are going to talk about the differences at the donor site and at the recipient site. So when we are going to harvest a full thickness skin graft, we know that the papilla are already gone. If the papilla are already gone, the new the new keratinocytes are not going to be formed, and the place from where you are going to harvest a full thickness skin graft is going to heal with fibrosis or scar formation. So it will heal by secondary intention. But when you are going to take a split thickness skin graft, the epidermis is again going to regenerate, and that area can again be taken up for using the graft. So it is very much important. So split thickness skin graft, so epidermis plus a small part of dermis. So these are, you can take it up from the thigh, or you can take it up from the scalp, and you can use it for the larger areas, because the donor site heals and you can take it up again, and it contracts significantly. What happens is, when you are going to take up only the epidermis, after placing the graft, it is going to contract, and because of that contracture will develop, and it is going to cause a poor cosmesis. So if you remember a photo which I had put in the previous chapters, this is a patient who is having a skin graft. So let's see where I'm trying to take you. Just open the chapter in your so yes, this was a skin grafting which was done by me. So see, this is a split thickness skin graft. So only the epidermis and some part of the dermis is used, and you can see it is very much thin. And why do we do meshing? So the meshing is going to help. First thing, it is going to prevent the collection, it is going to prevent the seroma formation, and all the fluid is going to ooze out. So firstly, it is going to make sure that the skin is getting stuck to the underlying granulation tissue. And the second important thing is, the meshing is going to increase the surface area of the graft, and because of that, the graft can be actually spread over the larger surface area. So meshing, it is going to be useful in the two ways. But always remember, the meshing is also problematic, because the meshing is going to cause poor scar formation. So if you are doing it on the face, so always remember, on face you are never going to use a split thickness graft, because of that there might be scar contracture. If you are going to do meshing, it might cause a very ugly scar. So it is always something to be taken care of. Now we are going to talk about the full thickness skin graft. So what is the full thickness skin graft? It is epidermis plus full dermis, and you are going to pick up the graft from the groin. It has better cosmesis, less contracture, and it is durable. And also remember that the donor site must be closed primarily, or the donor site needs to be healed by secondary intention. So you are healing checking the cosmetic wound over the chest. You take up a full thickness skin graft from the groin, and after taking up from the groin, you are going to close the groin incision, or you might leave it open. A groin scar is still acceptable, but a chest scar might not be acceptable for a lady. So you should know that you are taking a skin somewhere else, and that place it needs to be healed by either by a primary intention or either by a secondary intention. A composite graft means you are picking up the cartilage. So sometimes you take up the ribs and you are going to construct the pinna. So conchal cartilage might be used, or even the rib or the costal cartilages can be used to give structural support. But here only limited size and small type of reconstructions are possible. Cadaveric allograft, we saw that we are going to use from it tissue banks, and it is a temporary material which is going to prevent the skin water loss, and it is going to provide a temporary barrier between the environment and the burnt surface area. And there are some dermal substitutes like collagen dressings which are actually manufactured. They are not harvested from anywhere, and they can be used for secondary reconstruction. So you put the collagen, you heal up the granulation tissue, and then actually you can place a split thickness skin graft. So it can also harbor infection, and these are very much, the collagen dressings are expensive. So what happens is, a graft does not have a blood supply, so it is like a hostile person. Jahan main jaunga, wahan se main khaunga. So when the graft is being placed there, what happens initially the wound, so this is the wound bed. So let's consider this is going to be the wound bed. So whenever you are going to place a graft over this wound bed, what happens is, initially the blood supplies from the edema which is going to settle around. So initially the blood supplies from the edema, and that edema, it is because that edema is going to give the nutrients to the graft. That is called as imbibition. It occurs in the first 48 hours. It is going to occur for the first 28 hours. Then what happens is the vessels from the donor tissue are going to grow upwards into the graft, but the graft tissues are still not anastomosed here. So that is called as inosculation. It is the inosculations, the vessels are going to link up, and then the vessels are going to anastomose with each another, and then they are going to form new vessels. So this process is going to take till 5 days. So till 5 days this process is happening: plasma imbibition, inosculation and revascularization. But whenever there is going to be complication with seroma, hematoma or infection or the movement of the graft, when the graft is going to move shearly, the graft is not stabilized at a place, then that is the time the blood vessel formation does not occur, and hence the graft is going to fail. So whenever you are going to do a skin grafting, make sure that the area is not dressed for next 5 days minimum. Next 5 days no dressing of that region, and always that region should be totally immobilized, or else the graft uptake won't happen. So it is very much important for you to know. Another thing is, in split thickness skin grafting, what happens is you are not taking the dermis with you, and all the sebaceous glands and all the oil secreting glands are in your dermal region. So whenever you are going to take a dermal graft, or whenever you are going to take a full thickness skin graft, the problem is that the patient is not going to have the sebum secretion on that skin, and the patient is going to have the dry skin. So lifelong the patient needs to apply oil to that skin, so that the skin is going to remain hair free and oil free for throughout the life. Because the hair follicles and the sebaceous glands are in the dermal region, the deep dermal grafts, the full thickness skin grafts don't need oil application, but the split thickness skin grafts require oil application. So another important change in this is oil application. So it is very much important. Then a word about the tissue expander. So what happens is, see, this is the chest wall, and now this lady needs to put an implant, or there needs to be a surgery which is to be done on the chest wall. So what do? We are going to place an implant in the chest wall which has a connection outside. So what happens is, we slowly we are going to fill that balloon. So after slowly filling that balloon, what happens is the skin is gradually going to increase in the size, and because of that the skin now becomes redundant, and this excess skin can be taken off and then it can be applied somewhere. So this is the phenomena where you can actually use what is called as a tissue expander. So what happened, see, this is a lady, she had a lesion over the scalp and which needs to be excised, but this much big excision will cause a lot of defect on the scalp. So what did they place? They placed 4 tissue expanders beneath her scalp. So now you can see that these tissue expanders have expanded the skin over the scalp, and when you are now going to excise the lesion, when you are now going to excise this lesion, this tissue expander, the skin which has gone from the tissue expander, will come in between and healing is going to take place. So whenever you feel that this is a benign disorder, it needs to be removed, but I have a lot of time for it, I don't need to rush for it, then what you are going to do is you are going to place the tissue expanders in the nearby region, so that the skin will extend itself, the skin will grow itself, and then you can actually anastomose the skin in the midline after excision of this whole you can say the lesion. So it is very much important. So balloon expander placed subcutaneously and progressively inflated over weeks, it stretches the overlying skin. The expanded skin can be used to deal with the adjacent defects with identical tissue match and color. So it is nothing but a balloon expander. Common uses are used in breast construction or scalp reconstruction, very much important. And complications are, it exposes the region to implants, and there might be infection, pain or temporary deformity. The patient won't be able to use the neck movements properly, or the patient might have restricted chest wall movements because of that. So there might be a complication. Always remember that breast implants come with a proper black box warning that they can lead to anaplastic large cell lymphoma in the patient. So whenever a patient is using a silicone implant, he or she needs to be screened for regular follow-ups for anaplastic large cell cancer. Another take-home point, very much important MCQ point for you. So you should know that whenever you are dealing with a patient of silicone grafts or silicone tissue expanders, patient might have something which is called as development of malignancy later on, and patient needs surveillance and counseling. And smooth implants have significantly lower risk. So if that implant is having textured surface, there are more chances of development of malignancy in that region. So what is fat transfer? So whenever some eyelid, or whenever you are doing some lift surgery, so cheek, one side of the cheek after doing a facial fracture, one side of the cheek is being significantly brought down and another cheek is very good. So you need to transfer a fat into this type of cheek, that is called as lipofilling or lipotransfer. So what happens is, you are going to take the fat from abdomen, you are going to just liquefy the fat, and then you are going to inject the fat in the recipient region. So absorption rate is 20 to 80%. So what happens is, even if you are going to put the fat in the region, temporarily there will be some the look might become fatty, but later on, depending on the technique and vascularity, that fat might necrose on itself, or it might be absorbed, and multiple sessions are therefore required. So you might see this fat transposition surgeries, plastic surgeons doing it, putting it on Instagram about doing how do they do these surgeries. So that is nothing but take fat from the abdomen, and then you are going to put it inside the cheek, and use for breast reconstruction, facial volume restoration, scar treatment, or hand rejuvenation. So whenever you are going to have a hand surgery, after doing that, the fat of the hand is lost and the arms look unequal, so that time you can do the fat transfer surgery. What happens, there can be fat necrosis, calcification, and unpredictable volume retention. So that is very much important. Now coming down to the flaps. So what are the flaps? So whenever you are dealing the flaps, you should categorize the flaps into, so let's draw a table which is going to tell you how do we classify the flaps. So how are we going to classify the flaps? So based on the source. So what are those based on the source? It are cutaneous flaps, fasciocutaneous flaps. So only fascia and the skin is taken. Then you are going to talk about the muscle which you are going to take. We saw that in the angiosome concept. So when we are going to take the muscle, they are called as myocutaneous flaps. Then if you are going to take, yes, along with the muscle you are going to take bone, these are called as osteocutaneous flaps. So it is the osteocutaneous flaps. So when you are going to talk about the flaps, you are going to check about the movement. So as we say, if the person is going to the other hostel, or if the patient is going being a localite. So locally you are displacing the tissue, or you are taking the tissue to the distant region. So you are going to take the tissue to the distant region. So locally you can rotate the skin. So you can just rotate the skin from above downwards or downwards above. So these are called as rotation flaps. Another flap is called as a transposition flap. So we are going to talk about these flaps tomorrow in detail, but I am just telling you so that you can get time to revise about it, and then we'll talk about it tomorrow. Or you can have an advancement flap. And distant type of the flaps, wherein the flap is taken from one region to another, it is called as a distant flap. It might be a free flap, or it can be a pedicled flap. So a pedicled flap is like a PMMC flap, or latissimus dorsi flap, and free flap is nothing but it is like a radial forearm free flap, or it can be free fibular flap, FFF, free fibular flap. So we'll discuss this table tomorrow again, and then we are going to talk about how are we going to deal with the flaps. So I hope it is clear. So thanks for attending the lecture. Tomorrow we'll again meet at the routine time. So till then, if you have any doubts, you can post them in the comment section, ping to me on Instagram, or you can post to me on the WhatsApp. I'll be more than happy to help. So thank you for attending the lecture. Till then, take care, bye bye, and good night.